Hi, everyone. Welcome to our podcast. My name is Joan Chen. I am a clinical associate professor at the University of Michigan. I specialize in basically all things esophagus. And we're talking about eosinophilic esophagitis today, one of my favorite topics.
And my name is Ofer Fass. I am an assistant professor at Northwestern Medicine, Northwestern University. I am also an esophagologist. I take care of all sorts of esophageal disorders, among them reflux and also EoE, another one of my favorite topics as well. And I'm very excited to be here with Dr. Chen to discuss this.
That's awesome. So one of the most fun things to talk about in EoE is kind of this yearly update, because I think it's a pretty new disease, relatively speaking. And it seems like every year there's something new to talk about.
Agreed. And, I'd be curious to hear from you, Joan. What's the most exciting developments in EoE treatment this year and why?
That's a great question, because there's been a lot of development. But I think one of the shortcomings that I see in the current medical treatment for EoE is kind of this nuisance of having to take long-term medications daily or twice daily, for example, topical steroids. So to me, one of the most exciting trial from this year is using this agent called EP104-GI. And this is a injectable, local, and controlled release esophageal fluticasone. It's steroid formulation that was used in a trial called Resolve trial. And the initial findings were published or were presented at the Digestive Disease Week. So in part one of the trial, and this is first of all, phase 1b/2 clinical trial, which means that it's small scaled. It's mostly a safety assessing, dose finding, and just initial efficacy trial. A single injection of this agent, EP104-GI, in the esophagus was done at baseline, and the subjects then underwent follow-up endoscopy at 4, 12, and 36 weeks. Because it's a small-scale study, they tested 10 escalating dose levels with only 3 subjects at each dose level, so a total N of 30. And the initial data showed that there's a mean drop in the peak eosinophil count from baseline of up to about 80% at 12 weeks and 65% at 36 weeks following just a single injection at baseline. And they also found that about 60% of the subjects demonstrated eosinophil count of 6 per high power field or lower. So in a second part of their study, they also looked at higher doses of the medication, and that demonstrated endoscopic score improvement, the ERAF score of up to 62% at 36 weeks after administration. So after the part 1 data, they looked at the higher 2 doses of EP104-GI, and they selected the doses for optimization and randomized with placebo for the patients, the subjects, to receive the higher 2 doses of EP104-GI. First of all, they looked at the safety data and found no serious adverse events, no concerning lab abnormalities, and no signs of adrenal insufficiency. But the preliminary data showed that there's greater histologic and symptomatic response that were achieved at higher doses. But the trial is really still ongoing, and so the final results are TBD. But I think this is very exciting to have a potential novel treatment option where this local, long-acting submucosal corticosteroid formulation of fluticasone may be right for some EoE patients. And I'm thinking about my patients that have a harder time sticking to a daily therapy, and maybe, those that can't do dietary treatments.
Yeah, no, I agree. I think EP104-GI sounds like a really exciting treatment on the horizon. I like that it's long acting, and having another tool in our armamentarium of treatments is always helpful, especially in a disease that can be as complex as EoE. In terms of what I'm kind of excited about the EoE treatment in this past year is more related to Dupixent or dupilumab. Now, we know that this medication has been on the market for a few years, but there's been some interesting studies over the past year looking specifically at its efficacy in some of our most challenging patients, those who have very refractory fibrostenotic disease or narrow caliber esophaguses. So there were 2 trials that were presented at the most recent DDW. There was a remodel trial that looked at esophageal distensibility and the impact of dupilumab on that. And then also the DISTRICT trial that looked at treatment-refractory severe fibrostenotic patients. So with the remodel study, this was a phase 4 randomized controlled trial. Patients were randomized 2-to-1 to Dupixent or dupilumab weekly versus placebo. 69 adults were enrolled, and the primary endpoint was the distensibility plateau. So that's the maximum diameter on an endoflip catheter within the esophageal body at 24 weeks. So the distensibility plateau was shown to significantly improve versus placebo, and there was a bigger effect if the baseline distensibility plateau was less than 17 millimeters. EREFs improved substantially. There were no serious adverse effects, and currently there's a 104-week open-label extension that's planned. So we'll stay posted to see what that shows at the 104-week follow-up. Now, the DISTRICT trial, this looked specifically at patients with severe stricture or requiring frequent dilations. This was an interim analysis that was presented at DDW. They looked at the first 10 of a planned 20 patients. These patients were some of the sickest EoE patients we care for. They had a baseline peak eosinophil count of 143. EREFs was 7, so that's pretty severe. But at week 24, these patients showed 80% histologic response. Peak eosinophil count decreased 96% to 5.5. So that's a pretty dramatic improvement. And the EREFs decreased by 57%. The minimum esophageal diameter improved from 12 millimeters to 16 millimeters. That's a 33% increase. This is a very objective and patient meaningful response. And similar to the remodel trial, no serious drug-related adverse effects. So the takeaway for me here is that we should think about using biologics maybe earlier in the treatment pathway for these patients, especially when we have patients who are very sick with severe disease. Yeah, biologics might be well positioned as a first-line therapy.
Yeah, that's certainly very interesting and potentially could really change our EoE management paradigm here. What about our understanding of EoE? Has there been any updates on whether the disease is still rising? Whether, I remember EoE used to be considered a rare disease, but I don't think it is anymore, right?
Yeah, I think that's fair, right? I don't think we can really call EoE rare anymore. Recently, over the past year, there was a Swedish population-based study called the Espresso study that really pointed to the rising incidence and prevalence of EoE. So this was a nationwide histopathology cohort. It included 28 Swedish path departments, which I think is all the path departments they have in Sweden. So this was a countrywide study. They identified 5,437 incident cases between 2005 and 2021. Incidence increased from 3.27 overall per 100,000 overall to 6.28 per 100,000 between 2017 to 2021. And there was no plateau. So we're seeing this continue to rise, and it could continue to rise. It just hasn't been looked at beyond 2021. That's a 30% per year increase. Also kind of interesting here is we see a bimodal age pattern. So there's a peak for patients between the age of 15 and 19 where we see an incidence, especially among male patients. And there seems to be a second peak between 40 to 45 for men and 50 to 55 for women. 2021 prevalence was 0.05%. The lifetime risk, and I think this is really the most shocking number here, is 1 in 129 for men, 1 in 322 for women. So in my mind, the key thing here is that the 1 in 129 number is striking. I think it's something that should be really reinforced with doctors who refer to gastroenterologists, and our index of suspicion for EoE should be pretty high.
Yeah, that's really interesting. I find that bimodal distribution also intriguing. So that's data from Sweden. I recall that there's some also regional variability data and also incident prevalence of EoE data recently that looked at the global incidence and prevalence of EoE in the last few decades. This was published in Clinical Gastroenterology and Hepatology. They reported a global incidence of EoE to be 5.3% per 100,000 inhabitant years. The global prevalence to be 40 cases per 100,000 inhabitant years. And with, reported gradual increase, like you were mentioning, over the years and decades. What's really really interesting from this study was that the pooled incidence of EoE was higher in certain populations, so the higher income countries, male, as we have known, and North America countries as opposed to Europe and Asia. So this regional difference can be really interesting. And the other thing is, whenever we're talking about this rise in diagnosis of EoE, some people attribute that to the phenomenon of this disease being more recognized, and maybe we're looking for it more, and that's why we're diagnosing it more. But there was that Denmark study earlier that showed that the increase in incidence and prevalence really outpaces the increase in endoscopic biopsies. And so we really can't say that, there's an increase in diagnosis simply because of the increase in awareness.
Yeah. And it'll be very interesting to see with future studies what might be driving this increasing incidence, because I don't think we have a really good answer right now. There's obviously some hypotheses, but I hope there'll be more epidemiologic studies in the future that might really drill down as to why we're seeing this phenomenon.
That's right. So speaking of biopsies, have there been any updates on how we can measure EoE disease activity?
That's a great question. As of now, diagnosis still requires histologic confirmation in patients with esophageal symptoms. So that means, obtaining endoscopic biopsies. Minimum 5 to 6 pieces of tissue should be obtained from multiple levels of the esophagus, proximal distal or mid-esophagus, distal esophagus. There are some other technologies that are being looked at. There is a active multi-site esophageal string test study that's ongoing. There was also a recent study that was published in the end of 2025 looking at an economic analysis model of the cost benefit of doing transnasal endoscopy, specifically in a pediatric population. The key argument here is that with transnasal endoscopy, you have fewer sedated procedures without losing diagnostic yield. So it'll be interesting to see if this is something that will make its way into the adult EoE population or will become a more common modality for testing. But the thing that I found probably the most intriguing, while not ready for prime time quite yet, is using simply the blood eosinophil count as a diagnostic signal. So there was this multi-center prospective Italian study within the past year that looked at the peripheral blood eosinophil count at a threshold of 155 cubic millimeters, showing high sensitivity and specificity for diagnosing EoE in dysphagia patients. And they showed an area under the curve or an AUC of 85%. A threshold of 325 per cubic millimeter predicted histologic remission, although with lower diagnostic accuracy. So these accuracies, these AUCs, I don't know if they're quite ready yet for standard diagnostic use, but very compelling to have a non-invasive or a minimally invasive option available to patients. So I hope to see this work continue to develop over time.
Absolutely. Yeah, we all know that these EoE patients, they undergo a lot of endoscopies every year. So anything non-invasive, could really be helpful for managing these patients.
Absolutely. And as we've been talking a lot about what's coming up in the horizon and more future-facing questions, my question for you, I guess, is where do you see EoE care heading in the next 5 to 10 years?
Well, that's a great question. So I think that as we are seeing more and more treatment options available, but yet there's not one single, best solution for all EoE patients, more and more we're going to be talking about shared decision making with the patient. So what that means to me is that patients should have discussions with their healthcare providers about potential therapeutic options, and including education on efficacies and side effects of each of the therapeutic options, but also taking into account patient preferences and their individual situations. And instead of this, what we're used to, this unidirectional conversation of the provider telling the patient what they should do next, it should be a bidirectional communication, and maybe even potentially involving multidisciplinary discussion between GI, allergy, dietitians, and maybe even patients' primary care providers in certain cases to help come up with a tailored decision for each patient. And, there's evidence that show that shared decision making is more acceptable to younger patients, which is exactly the patient demographic that we're talking about in EoE. So I think this will really be received well for patients in EoE moving forward.
Yeah, absolutely. It sounds like we're moving more towards a personalized approach for EoE.
Absolutely. So we talked a lot about recent studies in EoE. Do you have one key update from this year that you would like to highlight that will help providers manage EoE move forward?
Absolutely. I think we've talked about a lot of great studies and a lot of updates that are coming our way here. Probably something that I do want to bring attention to that I think will be important, especially with the rising incidence of EoE, are new therapeutic options. So there is a new biologic medication on the horizon. There's a medication called cendakimab. There was some published phase 3 randomized control trial data that was published back in September, demonstrating really great efficacy. So the 48-week data showed sustained symptom and histologic as well as endoscopic improvement, and that the medication was well tolerated. Just a little bit of background on this biologic. It's an anti-IL-13 antibody. It blocks both IL-13 receptor alpha-1 and IL-13 receptor alpha-2. So it's mechanistically distinct from dupilumab, which is really more of an IL-4 receptor antagonist or IL-4 receptor targeted biologic, but works on a similar pathway. So dupilumab has been the only approved biologic since 2002. Having a second option with a different mechanism of action changes the sequencing decisions for non-responders or steroid-averse patients. And it's always good to have more options for patients.
Yeah, absolutely. Well, I think that wraps up our podcast for today. It's been a pleasure talking to you about one of our favorite conditions, eosinophilic esophagitis. I'm really looking forward to what the next chapter of EoE management looks like.
I agree. Me too.